I'm Dr. Suvadeep. I am the consultant in the Apollo Hospital, Navi, Mumbai. So today we'll be discussing a very important topic that is asked in the that is one of the very important part of the EDIC Part 2 examination. That is a nephrology segment. So and critical care nephrology is one of the very booming subject. And in all European countries, the nephrology in the ICU is mainly managed by the intensivist, be it in the form of renal replacement therapy, be it in the deciding the modalities of the treatment of acute kidney injuries, and be it in the diagnosis, whatever it is there, that it is the domain of the critical care specialist. They decide even the hemodialysis, plate, CRRT, whatever form the dialysis is there, it is that has been done and decided by the intensivist. So it is very important to know this subject, and especially whenever you are going for an European examination like EDIC, you should be well versed with all topics of renal replacement therapy. In this session, we will discuss two clinical case scenario that is a part of EDIC 2 examination and two case-based scenario. So the EDIC 2, whenever we give EDIC 2, there are CCS and the CBS. So we'll discuss this session again on the same module, the way it is asked in the examination. While we discuss the case scenarios and the case-based scenarios, we'll go through the how we diagnose acute kidney injury, how do we identify various etiologies of acute kidney injuries, how do we manage acute kidney injuries, what are the indications of renal replacement therapies in the for the AKI in ICU, what are the various form. We'll discuss about CRRT at length, various modalities of the CRRT, forms of the anticoagulation, how do we win from renal replacement therapy, and what we'll discuss some of the common nephrological emergencies that we encounter in the ICU. Okay, so we'll come to the first clinical case scenario, case number 1. Let's read out the. So usually in the EDIC 2, either you'll be given a clinical case vignette or you'll be given a scenario. So this is a kind of typical case vignette like it is there. There's a 26-year-old male presented with severe pain abdomen related to back, with nausea, vomiting, and abdominal distension. On admission, he was tachycardic, tachypneic, saturation in the room air was 95%. His vitals have been given over there. His per abdomen, there's a soft, distended abdomen, but without any guarding rigidity, no rebound tenderness. On lab evaluation, it has been found his creatinine is 2.1. Urine output is not known because he has been just presented in the emergency. The initial ABG shows high non-gap metabolic acidosis with lactate of 9.3. His total count is 15,000, hemoglobin of 17.8, and a platelet of around 478,000. His liver enzymes was normal. He is found to have raised amylase lipase. Did the initial USC, no gallstone was found, no free gas on the diaphragm. Echo screen found to reveal to have normal LV function, collapsible IVC to normal aortic arch, and the X-ray has been displayed in the slide. Okay. So what are the differential diagnoses? Anybody among the
Acute pancreatitis,
okay, very good. It might be an acute pancreatitis. What are the other differential diagnoses?
renal colic,
Okay, it can be a renal colic. Okay.
It is acute pancreatitis with intestinal hypertension leading to acute kidney injury.
Acute pancreatitis. Any other thing apart from the acute
Ischemic mesenteric vascular occlusion or something.
Very good. It can be ischemic colitis. Very good. So it can be any cause of acute abdomen. An acute pancreatitis, it can be perforation, it can be mesenteric ischemia, diverticulitis, malrotation. So whenever somebody comes in acute abdomen, all these details we should remember. Now, among these things, perforation is a kind of basically ruled out because there is no free gas on the diaphragm, as we have already been told. Diverticulitis is usually not common in this age group. Usually, it's a problem in the older age group. Malrotation again, it usually happens in much younger patients, so it may be possibilities, but we'll keep this thing as a kind of lesser in the differential diagnosis. Ruptured aortic aneurysm we should always keep in mind. That is why we have given the 2D echo finding in the. So whenever somebody comes in acute abdomen, we should do a screening of the echo to understand whether this acute abdomen is whether it's a kind of acute chest pain or it's a kind of perforated or ruptured aortic aneurysm. So mostly it's an acute pancreatitis or it's a mesenteric ischemia. Appendicitis, again, somebody becomes septic with appendicitis can be as a possibility. So how do we confirm? So next question. So this is the typical questions that they are asked in the exam. So you'll give a clinical case vignette and they'll ask the differential diagnosis and they'll ask how to proceed. So how do we confirm?
CT was contrast. CT abdomen was contrast.
CT abdomen with an IV contrast. Everybody agrees to that? His creatinine
Ultrasound
is
abdomen, sir.
okay, ultrasound abdomen. His creatinine is 2.1. We do not know the urine output status. So that is the background. So how do we confirm? So CT is 1%. CT is CT with a contrast. Ultrasound. Any other? So if we talk about the confirmation of the diagnosis, ultrasound can happen as a kind of baseline screening because we do a lot of ultrasound in the ICU nowadays. But if we talk about the confirmatory test, is CT with a contrast, CT abdomen with a contrast. Now, whenever we do a CT with a contrast study, what is the risk that is associated in this case?
Contrast
induced
acute kidney injury. So he has already an acute kidney injury. This acute kidney injury can exacerbate after giving a contrast. So if you see the current guideline, all these life-threatening situations where the diagnosis is mandatory and diagnosis can change somebody's management, then contrast, we should not, the guideline says that we should not delay contrast administration to diagnose a certain disease if that changes the management. So there is no doubt that the CT with the contrast is the choice of investigations in this case. There is no way we can say that we will not do a CT abdomen with a contrast because there is a contrast associated nephropathy and then the patient will end up in the dialysis and all. If there is a risk of dialysis, we should explain to the family and then we should take it up. Whether the patient requires dialysis or not, that is a secondary thing. But we should always go ahead. But whenever we do a CT, then we should know what are the risk factors that can exacerbate the post-contrast acute kidney injury. It's called PCAK. That's a new term. So that has come, the post-contrast acute kidney injury. So what are the risk factors for post-contrast acute kidney injury?
Dehydration, any nephrotoxic drug like NSAIDs, metformin, and other nephrotoxic antibiotics, like and pre-existing renal injury.
Previously raised creatinine.
What is
hypotension?
Hypotension.
Hypovolemia.
Hypovolemia, very good.
Iodinated contrast.
So all contrast media are iodinated contrast media. It can contain less iodine, it can contain more iodine, but all contrast media are iodinated contrast media. But
larger volume of the contrast. Larger volume of the contrast. Yeah.
Larger volume of the contrast.
Age more than 75 years.
Age, okay. So elderly people.
Higher contrast volume also more than 100 ml if they are using maybe.
Okay. So
CKG.
Tell me, sorry.
CKD.
CKD, somebody with a baseline chronic kidney disease. So if we see the guideline, the those most prominent risk factor for post contrast AKI is the chronic kidney disease. Somebody who already has a kind of baseline kidney dysfunction, they are the most prominent people to develop post contrast acute kidney. If somebody has a CKD whose GFR is below less than 30 ml per kg per minute per meter square. Diabetic nephropathy or somebody with a diabetic, they're very prominent risk factor. Anybody with a diabetic, we should be very, very careful giving a contrast in those patients. And as you have told, somebody who is hypovolemic and somebody who has a LV dysfunction. So they are the very prominent cause. If those kind of patients are there, somebody elderly patients with a poor LV functions, a diabetic, and now on the top of it they are dehydrated, then probably the contrast induced acute kidney injury will develop more prominently for those patients. So what are the preventing measures that we take for contrast induced AKI? Is there. So most important measures that we take is peri-procedural volume expansion. So if we need to have one measure, that is fluid expansion, volume expansion. So if we go by the KDIGO guideline, then volume expansion by at least 1 ml per kg per hour for at least 12 hours before and after the procedure needs to be contemplated to prevent post-contrast AKI. Whether these values are, whether numbers are absolute, no. It depends on the patient to patient basis. Somebody with a LV dysfunction, pre-existing LV dysfunction, obviously will not give that much of volume. But we should always hydrate. We should always correct the underlying hypovolemia. Suppose this patient has come, they are already, this patient is already in shock. So we should always try and optimize the volume status before proceeding for the contrast administration. Secondly, we should use isoosmolar or low osmolar contrast media. Nowadays, all centers, they usually all contrast media are low osmolar contrast media. In a stealth cysteine, always have a very doubtful evidence, so we do not know whether it actually benefits or not, or whether it is just a innocent bystander. But we should always avoid other potential nephrotoxins, like this patient we should avoid, like metformin we should avoid, aminoglycosides we should avoid insects. All these other potential nephrotoxins we should avoid. Okay. So keeping inside of other contrast-induced acute kidney injury, what are the other common causes of acute kidney injury in the ICU? Like this patient has come in a acute pancreatitis. So the commonest cause of acute kidney injury in the ICU is sepsis, or if it is acute tubular necrosis. There is a majority of cause of acute kidney injury in ICU. There's some acute glomerulonephritis. They sometimes comes as an RPGN, comes with an acute nephritic syndrome. They comes in acute kidney injury. You should always identify. Somebody young comes with an acute kidney injury with a creatinine of raised creatinine, high blood pressure. We should always think of acute glomerulonephritis. Obstructive nephropathy becomes one of the important cause of acute kidney injury, especially in the elderly. There are drug-induced acute kidney injury and other hemolytic uremic syndromes, TTPs. All those things, they constitute 5 to 10% of acute kidney injury in the ICU. Let's continue the case. The patient was well hydrated, CT abdomen with IV and contrast was done. CT was suggestive of acute severe necrotizing pancreatitis with splenic vein and partial portal vein thrombosis. CT severity was 8, on admission bicep score was 2, SOFA score was 3. Next 2 to 3 days, tachycardia, tachypnea settled, creatinine, good that he didn't develop acute kidney injury. Creatinine on day 3 became normal with a normal urine output. He initially was on fentanyl infusion, which gradually tapered. He was started on the oral diet. He was started on therapeutic anticoagulation and shifted to the ward. Good, very good. Day 5-6 in the hospital, he was shifted back to the ICU with hematuria. The LMWH was temporarily withheld. All other coagulation parameters were checked. They were found to be normal. LMWH were restarted next day after gradual clearing of the hematuria, but started to have hematuria again. Blood evaluated for the clots. They found to be negative. He was stable except the fact that he started complaining of the left flank pain. And the creatinine on day 6 rose to 1.2, and the previous day it was 0.7. Although the urine output was maintained. So next question is, does he have acute kidney injury?
Yes, sir.
Okay. Anybody else?
Yes, sir.
Everybody
Uh,
else? His
According
creatinine is
to
normal.
creatinine criteria, this is AKI, as his creatinine is raised more than 0.3 from the baseline.
So how do we define acute kidney injury? That is the next question.
Grade 1 greater than 0.3 raised from the baseline, or
Okay.
GFR greater than 1.5 times the baseline, or urine output less than 0.5 ml per kg per hour for 6 hours, 3 hours.
Good. So we do not calculate the GFR. If you go by the AKIN guideline, so the acute kidney injury is diagnosed whenever that is AKIN guideline. So whenever the serum creatinine rises more than 0.3 milligram per DL from the baseline within last 48 hours, or increases by more than 1.5 from the baseline, creatinine rise more than 1.5 from the baseline within the last 7 days, or drop in urine output by less than 0.5 ml per kg per hour for more than 6 hours. If any of the criteria meets, they should be termed as acute kidney injury. It can be stage 1, stage 2, stage 3. You should all remember that thing. I'm not going into details that thing, but for the exam purpose, you should know what is stage 1, stage 2, stage 3, and in the day-to-day life also, whenever we practice the critical care, we should know what is AKIN stage 1, stage 2, and stage 3. You should always refer AKIN staging. Okay. Any creatinine rise more than 0.3 or more than 1.5 from the baseline, and urine output drops. These are three criteria we should remember whenever we talk about the acute kidney injury, whenever we try to define acute kidney injury. So there is an acute kidney injury care bundle that is set by the KDIGO AKI bundle that you should always know. So it encompasses the definition. How do we define it? We have discussed. How do we classify it? Again, that we have discussed. How do we diagnose it? That is done by STOP criteria. So like STOP means there are four major etiologies of acute kidney injuries. One is sepsis and hypoperfusion. Second is toxicity. Third is obstruction. Fourth is parenchymal kidney disease. There are various recommendations, the bundle recommendation that has been given by the KDIGO that we should remember, like whenever we detect somebody in acute kidney injury, how do we proceed? We evaluate the volume status, we discontinue all the nephrotoxic drugs, we consider alternative to radiocontrast procedures, check the changes in the drug dosing, review the antihypertensive medication. Somebody who is already hypertensive, has a baseline blood pressure of 130, 140, suppose goes down the BP of around 100, 110 systole, that means they are already relatively hypotensive. So we should always try and maintain and decrease the antihypertensive medicines from his drug schedule, and then stop or temporarily withhold those medicines for the temporarily or for the time being. We should avoid hyperglycemia. We should request creatinine daily, and daily volume chart and fluid intake output chart should be maintained, and we should request an urine analysis and renal ultrasound. And we should seek a nephrology consultation when there is a AKIN stage 2 or 3. We should understand AKI. We do not understand the etiology of the AKI. We should seek the nephrology consultation. So there are all the KDIGO guidelines. They have told that we should have this bundle approach to identify the patients under acute kidney injury and then manage. So we'll proceed for the discussion. On day 7, he started having drop in urine output. His creatinine on the previous day was already started rising, but on day 7 he started having drop in urine output. He started complaining bilateral flank pain. He didn't have any fever. He was tolerating feed. He was hemodynamically stable except mild tachycardia. Over the next 8 hours, his urine gradually declined and he became complete anuric, and he remained anuric. Okay, everybody got that case beneath. So what are the probable cause over here for this patient? What are the probable cause for this patient to have complete anuria for the period of 8 hours? Anybody?
As the primary diagnosis of the patient is acute pancreatitis, so it can lead to a severely increased intra-abdominal hypertension that may lead to this AKI. This is one possibility, and another is maybe use of any nephrotoxic drug for his pain to subside his pain, like any sorts of use of any NSAIDs or like this. And
Renal-
another another possibility is sepsis. As acute pancreatitis is also a risk factor for sepsis. It can lead to secondary bacterial infection that can lead to sepsis, hypertension, and lead to AKI.
Okay.
Vascular thrombosis, vascular complications also, renal vascular problem.
Vascular components, very good. And anything, very good. So the
And acute pancreatitis is a pathogenic condition, so it may lead to the renal vein thrombosis also, as the patient has vein pain.
very good. Good. I'm very happy that you are thinking of all those things. Very good. Then, so the most important term over here is sudden anuria. Whenever we talk about somebody has become septic and hypotensive and then developed AKI, they usually become oliguric and then become anuric maybe over the next 24-48 hours of time. So it might take certain time. But somebody who was previous day, somebody was urine output was absolutely fine, but within 6 hours suddenly become anuric. Then there are only 2-3 possibilities that we should think of. The sudden anuria, whenever we deal with sudden anuria, think of acute urinary tract obstruction, acute glomerulonephritis, like RPGN kind of thing, and some vascular catastrophe that someone has already told, like renal vein thrombosis, renal arterial thrombosis is most common, because this patient already has a kind of mesenteric ischemia. They might be procoagulant. And how do we identify? Because this patient has another typical problem. So what is the history of this in this patient? This patient started having hematuria and then started developing acute kidney injury, and he was having bilateral flank pain. And then he became anuric completely. So what are the things that we should think? How do we diagnose? No, it's already been given. Again, we'll sort out, we'll do a CT abdominal angiography for the renal vasculature, because vascular cause catastrophe should always be ruled out. Somebody becomes sudden anemic. Okay.